So if we are getting these out there, then people are now going to say, oh, I heard about it. I presented a poster, not a talk, in the vascular meeting in Amsterdam also this year, and I got already 2 emails from physicians because of these presentations that now saw patients with Olien and Maffucci and want to know more information so they can care for them better than what they think they could. So this is what we try to do with that. When we present that work, is try to also to create awareness around the clinical field. So the number that we find with them, I'm trying to make a picture in words of a patient with Olien and patient with Maffucci. So these are the age of the patients with Olien. This data is for the patients with Olien. So in the review, the median age was 7 years of age. But you can see that the time of the diagnosis ranged from 0 to 58 years old. But most of the patients were diagnosed around 7 years old. But when we go to the survey, it's actually a little younger. You told me that the age was 4.8 years old, and the range goes from 0.2 to 6.4. So it's between, I would say that it's between 4.8 and 7 years old when most of the patients are diagnosed with Olien disease. And the other thing that we were very, there is, Dr. Flanagan touched a little bit on that today, saying that most of the patients have one side of the body affected only. I always had questions about it, and this was one of the things that we wanted to know with going back to this analysis. And you can see here that actually in the review, 64% of them had both sides affected. Oh, actually had one side of the body affected. And in the survey, 45 of them have one side. So to me, it's actually half and half. If you look at this number, it's actually, in the survey was 45, and in the literature was 62, but then when you get the in-between, it's around 50. So I don't think that really most of the patients have only one side affected. I think it's half of them, almost half of them have one side, and almost half have both sides affected. And then, these are for the patients with Maffucci. For the patients with Maffucci, the main thing in terms of age was that they were a little older when they were diagnosed. So they were diagnosed in the literature at 11 years old, and in the survey at 6 years old. So you remember the Olien was 4 and 7, here we have 6 and 11. So they are a little older, and I think this is because we know that the vascular problems happen later. So this is when you get the diagnosis of Maffucci later on, because the vascular problems tend to appear later in life. That being said, we will see that 10% of the patients with Maffucci had a vascular problem before age 1%. And this was a change from the literature. The literature says 25%, but we actually found 10% in the literature. And in the survey, you gave me 15. So some patients are actually much younger at the diagnosis. All these things, I need to know the answer. Why? Why some patients are affected when they are born? Why some patients only get affected when they are 54 years old? Also. So, so here you see that the vascular problems happen later, 13 years old, and in the survey was 9, so between 9 and 13. So you usually have the enchondromas and then the vascular problems. We already knew that, but it's giving us more specific ages to us to. These all will guide guidelines for tests that should be done, right? So what should I be doing and when? So knowing these ages is very important for us to define that. And then you can see that this is like 45% of the patients in the literature had one side of the body effect. So again, it's almost half and half. Half of them have one, half of them have both. The survey gave me 29. The problem with the survey, and if there are patients with Maffucci syndrome here, others, answer the survey is really helpful because you saw I only have 36. So to get any meaningful statistical analysis out of 36 patients is really hard. So I'm still left with the literature. I have to go by the literature because I don't have other number. The literature gives me 199 patients. I don't have any other number that can help me to create guidelines. That's not the literature review. And then most of the vascular anomalies, the vascular problems, were in one side of the body, and most of them were in both, like, that didn't matter. They were hands and feet. They were not more in the hands or more in the feet. But you can see that but it's almost half again. So overall, this thing of one side being more affected than the other happens, but happens in 50% of the patients. And 50% of the patients have enchondromas or vascular anomalies in both sides of the body. Then this is, to me, very, very interesting, and it has implications on us doing research on trying to find what the genes call. Is a patient that has intellectual disability or had developmental delay different from a patient that only has 4 enchondromas and nothing else? Is there a genetic cause that's different for these patients? So what we found with the survey, and this is all from the survey, I don't have any of this information in the literature. So this is when I tell you, like, if it was not for your help, I would not learn at all about Olea disease and Maffucci syndrome. And we are now trying to teach other people about it because this data, it's not out there in any paper to anybody to read. So you told me that some of the cases were actually familial, right? There were 5 families that answered the survey and told that their Olea disease is familiar in their family, and one with Maffucci syndrome. The question that I have now is, do they really have Olea disease and Maffucci syndrome? Because as I told you, and you heard also from Dr. Flanagan earlier today, there are some other enchondromatosis that we know the gene, and that they are actually familial, that they can be passed from one generation to the other. So maybe these patients are misdiagnosed, and they actually don't have Olea disease and Maffucci syndrome. So now I have to go further and try to identify what is actually causing the disease on them, and try to differentiate Olea and Maffucci from the other ones that we already know. You told me that 30 patients with Olea had teeth anomaly. This is 30 out of 126. It's a lot. I know that there are other diseases that are characterized by enchondromas that have teeth anomaly. But I didn't know that Olea disease and Maffucci syndrome also had. Maffucci is much less, it's 4, but it's 4 out of 36. So this is the other thing that we found, that maybe that is because they are misdiagnosed, but it's too many to be misdiagnosed in this case. So it's mainly it varies, but it's mainly the enamel, hypoplasia of the enamel part of the teeth. So this was mostly what we found. And then you told me that 18 patients had developmental delay and 10 have intellectual disability. These patients need to be investigated with blood tests, with urine tests, because there are other enchondromatosis that go along with developmental delay, intellectual disability, and I now need to know if they have one of them. They again may be misdiagnosed. Or it may be that, yes, some patients with Olea disease and Maffucci syndrome have mutation in a different gene that also causes intellectual disability and developmental delay. And these are things that you will tell your physician, he'll say like, oh, no, Olea disease don't have intellectual disability, don't have development, and they'll just dismiss you, right? Because it's not their fault, they just don't know they cannot get this information anywhere else. Then the urine test that I told you that gives us a clue of all the disease, only 4 patients have ever done it. I do that in every patient that I see in my clinic. I have at least 20 results of urine in my clinic, and one of them is actually positive. So the patient came to our clinic saying that was Olio disease and ended up not being Olio disease because it got that as positive. So it is rare that you find because the disease is rare, but it needs to be picked up. Why? Because it makes a huge difference on what you tell the patient about chondrosarcoma risk, for example.
That's something an orthopedic surgeon can request, is that have to be something that comes from genetics?
The best thing you do is to look for a clinical geneticist. I'm not saying that every clinical geneticist will know how to do all the things, but if he doesn't, it's much less likely that any other physician will do it. And this is not anybody's fault. It's not because they are ignorant or they don't care about knowing about disease. It's just that we all, in our days, are very specialized. Right? So orthopedic surgeon cares about the surgery and the orthopedic side of things, and they are not learning how to do genetic testing. This urine, it's not a checking your DNA, but it is a genetic test.
Is there anything, I'm sorry to interrupt, is there anything they need to specifically ask for when they request that, or is it just?
Yes, no, there is a specific test. It's urine organic acid.
Okay, and that will then cover whatever.
These will tell you if you have a high level of 2-hydroxyglutaric acid. If you email me later, I can give you the name of the result that you're looking for. But you can see how, what I want to show is how few patients have actually done this test. Then you have exostosis, that's the osteochondromas, that we talked in the morning and we just talked a little bit more. 15 patients had it with Olio and 2 with Maffucci. They do not, if they really have exostosis, they do not have Olio disease. So, but I just got in clinic, just this week, I got a patient with exostosis and vascular anomaly. And I know that she has exostosis because of the radiography, I saw it. And we did the testing, the genetic test, she has an EXT2 mutation. So this is actually something that may be a novel thing, that this patient with exostosis also may have vascular anomaly, but they don't have Maffucci. It's a novel disease, it's something that is not called by any name yet, and that we have to find a name because it's different. And it all matters because the genetic will be different, and if the genetic will be different, the treatment that we are looking for, that we are trying to find in research, will be different also. So, and then I said, okay, if you have exostosis, have you been tested for EXT1 and EXT2? Look, 15, only 1. So it just, I'm sorry, upsets me because it's like, it's like care that I know that patients need and they're not getting. This is not anybody's fault. It's just like we need to go around and do what Charlotte is doing, is spread the word about the disease, because if we don't do, people won't know what to do. So if you have exostosis, anybody here exostosis, go back to your physician and say, I need the EXT1 and the EXT2 testing.
We don't, Ellie doesn't have exostosis, but that was the EXT1 and the EXT2 was what genetics tested her for with the enchondromas, and it came back as negative.
But it's because,
Funnily enough.
but it's because sometimes the differentiation in the x-rays is not so easy. So to say if it's an enchondroma, to say it's an exostosis, sometimes the physicians are not very sure about, so they just prefer to go to genetic testing to make sure. Look, if they do more, better. If they do more, fine. The problem is doing less. Okay? So good that he did. It's good. Then the other thing that is very important is like a microarray. And we do have a patient in the Facebook group that actually has a deletion of some sort, I don't know exactly what it is, that caused the disease in her child. And because of that, they can have other things. So this is when a piece of, we have 46 chromosomes. They are supposed to be one from our mother, one from our father. And if there's a piece that is missing, then you have health problem. So if you have a piece of a chromosome that is missing with many genes missing, you can imagine that you won't have only enchondromas or vascular. You may have many more things. So this is why it's another blood test that I do for every patient. Patients that come in clinic with enchondroma, they get, doesn't matter what, a urine test, a blood test for the microarray. This is, and if they have exostosis, they will get PTPN11 mutation tested for, and EXT1 and EXT2 tested for. So this is basic. Everybody should be doing it to try to rule out other things. And it's important to rule out other things because the other things don't have higher risk of chondrosarcoma and higher risk of other kind of cancer. So IDH1 and IDH2 mutations were tested in very few patients. There was only one patient that had kind of glioma and it was positive. And some of the patients had their chondrosarcomas tested for. You can see that some of them were not positive, right? They had chondrosarcoma, 6 of them were tested for IDH1, only 2 came positive in patients with polio. So this is because I have no question IDH1 and IDH2, it's involved in the cause of polio and Maffucci. I don't think it's the only cause. And this is what my research is trying to find. Is like, first of all, how IDH1 and IDH2 cause it, and second of all, are there other things beyond IDH1 and IDH2 that are also causing it? And this is all important when we are talking on the final goal, that the final goal is to find a medicine that you all take and stop the enchondromas from appearing and stopping them from progressing and stopping them from causing any other health problems to you. This is what we want. And we will get there. It can take some time, but we will. It can take 100 years. People with cystic fibrosis have waited for 60 years, but they got a medicine now that's been very helpful. It's for 1% of them, but it's helping 1% of them. So it will take time. I'm not saying that we are going to do anything in the next year, in the next 10 years. I'm giving you a concrete example of CVF, that patients with cystic fibrosis, the gene was discovered, I think I don't even remember, but like I know that it has been 60 years ago, and only now they have some medicines that are helping 1% of them. But because of that, there are other drugs being tested and that will be helpful to many more. This is the main thing that we want with patients with polio disease and Maffucci syndrome also. So then we got to the ugly part of it that I don't like too much, but it's something that we need to know if we want to do something about it. The chondrosarcoma. So you can see here that the prevalence of malignancy in general, on the publications, the reviews that we looked at, were 53%. So 53% of the patients with Ollier, and the number is very similar to the patients with Maffucci that's in the next slide, had a cancer of some sort. The age was more or less around 28 years old, and it varied from 6 to 61 years old. And most of the malignancies were chondrosarcoma, 30% of them. This is the review, right? I'm talking about the review. But you can see that in the survey that you gave me was 22. So it was not so far from what is in the literature, 22 and 30. But the number of total malignancy is half in the survey. So if you want to be extra careful, you use 53. If you want to be more, I think, for the Olliers, I think this number is more realistic because we have 162 in the literature and we had 126 on the survey. So it's the numbers are more or less comparable. I don't think the comparison is valid for the Maffucci patients because it was 199 against 36. So I think for the patients with Ollier Maffucci, 25 with Ollier disease, 25 of overall malignancy, it's more a realistic number than 53. But it will be, I think closer, I want to believe that's closer to 25. I have my reasons to believe it's close to 25. I think the papers that are publish the more severe cases, and this is why we get 53% of them with a malignancy. Every patient that has malignancy gets to be published. The journals will accept. If you don't, the journal doesn't accept you. So then the scary thing is the brain cancer, right? Like, is brain cancer really more common among patients with polio? And we know that some of you here have the experience with that today. If you go to the literature, the review tells you that 16% of the patients with polio have a brain tumor, most likely in the group of the gliomas. But when we looked at the survey, it was only 2%. When I presented that in the meetings, one question that came up was like, but it may be that's because the patients with brain tumor actually didn't answer the survey. And it could be, right? But many of the people who answer the survey are actually not the patient themselves, are the parents. So I would be cautious about the 2, but I'm not as high as 16. I think 16 is inflated because of the literature publishing every case that has a glioma. But 2 may be too little because patients that had a glioma may not be alive to answer the survey, and then the parents of patients that are older are not the one answering the survey. Usually the parents that are answering the survey are the parents of children, and we know that's not at children age that they have the glioma. So I would not go as low as 2, but I think 16 is too many, is too much. Then the next cancer that affected the patients with polio in the literature was the gonadal. And this is mostly ovarian cancer. It's a specific case of ovarian cancer or testicle cancer. And we found 8% of the patients. But in the survey, I found 0. So it's more or less the same thing here. Maybe these patients, because they're older, they are not really answering the survey, and the parents are not answering the survey because parents of older patients don't answer the survey, and then I don't have the real numbers in here. But so, and patients with polio, of course, do not have vascular malignancy. They don't have vascular malignancy. So what I'm taking from here is, I need to worry when it's around 28 years old to start surveillance more closely on patients with polio for chondrosarcoma, for glioma, and for gonadal cancer. Okay?